Thursday evening. Now, why this particular session? Recently, last few months, we've come across quite a few cases, where we had this patients coming either as acute viral hepatitis, or they had this thing, and routine screening picked up an HIV infection. And what was interesting was that some of the patients, they came forward and they were quite frank about their behavior. So that was very interesting. Like one person said, I have bisexual behavior. The other person said, I'm a homosexual. So this is not an uncommon finding, not an uncommon observation. So I think in today's practice, what we are seeing is just the tip of the iceberg. And I'm sure there are very, very many more cases that we're not able to pick up in our day-to-day practice. And so some of the things that I found that were helpful instead of asking them direct questions was, supposing the young boy was HCV positive, 20, 21 years old. Then I would ask, are you staying in a hostel? At least for men, that's one question. So when they say, yes, we're staying in a hostel, are you staying in a room with 3 or 4 people within a room? And once they come out with that, then most of the times they come out with the information when we ask them, do you have any extra other behavior pattern? And that disclosure is very, very important, because today, I think you all should know what is gay ball syndrome. You can have gonococcal proctitis. Then you can have this HIV with HCV. Drug abuse is very common. So one boy, while we were treating him for HCV, when he was HCV positive, I just asked, because it's unusual for him to have an HCV infection at the age of 19 and 20. And then he said that he was actually having he was taking drugs, IV drugs. One other incident recently was a patient with head injury, and he was residing in Goa, and he was HCV positive. And he said that he was using ganja. So, the thing is, I think young folks who have some disorders or incidentally HBV positive, HCV positive, I think Dr. Varghese will highlight as we discuss how to approach these people. It's a very delicate question. It's a very sensitive question. We cannot readily ask such questions out of the box. So, there's an art of getting that information. So I think that is something that we want to discuss today. Dr. LVK has joined. Thank you, LVK. So I just gave a very brief introduction just to the topic as to why we took this topic. LVK, you can unmute and we can start. LVK, please unmute. LVK, you're muted. LVK, you're muted. Yeah.
Can you hear me, ma'am?
We can hear you, yeah. So I was just telling why this topic is important. So maybe each of you can just give 1 or 2 sentences only, and then we start with the case presentation. Why we have taken up this session. LVK and VT, few words. Why this topic? VT, you want to comment?
Yeah, because hepatitis B, hepatitis C, and HIV co-infection is an unknown thing. And whenever we find an HIV patient, it's mandatory that we also look for hepatitis B as well as C. At the same time, whenever we find a hepatitis B or C patient also, we have to look for HIV. Okay. Obviously, when you take a test for HIV, it should not be a routine writing of a lab request like that. You have to counsel them, because the results may go into the relative's hand or some bystander or other people, and it may create a lot of immense psychological trauma to the person who is found to be positive. But for that matter, even asking for an HIV test sometimes leads to so much of trauma. So the reason for asking for an HIV test should be explained to them, and then do the test, because we should always respect the patient, and their confidentiality and their secrecy has to be maintained.
Sure. Okay, LVK? Yeah.
Yeah, I think this. Can you hear me, ma'am?
Yeah, we can hear you. Yeah.
Is it clear?
Yeah, it's clear. I thought we'd take up the cases, but you can just give a brief introduction why this topic is important.
Importantly, that co-infection hepatology is both. We are more interested in looking at the HIV and hepatitis B and hepatitis C. Because when you have a co-infection, there are certain things where the progression of fibrosis is much earlier and much faster. Number two, we need to screen very appropriately. All these patients with co-infections cannot produce appropriate antibodies, so we have to have a high index of suspicion before you treat it. And there are certain definitely guidelines, like how do you treat Hep B and Hep C in presence of retroviral disease, that you have certain guidance. What are the new drugs available to treat it? So I thought we should probably
take up that, yeah.
Take up both hepatitis B and hepatitis C, so that you, important things is that how do you prevent the progression? First, how do you detect? How do you screen? How do you detect? How do you prevent progression? And importantly, the drug interactions between the heart therapy and these antivirals. That is what we need to do.
So
third thing is, how safely can we, if these patients decompensate, how safely can we transplant these patients? So these are all the things we thought we could probably focus on. So we could probably go ahead with the first case.
Yeah. So Bhargav, you're presenting along with Dheeraj is taking up a discussion, and there's one presentation from PSG, no? Right?
Ma'am, I am taking the discussion, ma'am. Harish.
Harish is taking discussion. Okay. And the first case is by Bhargav, and second case is by
Harish.
By Harish. Okay, fine. Take over. Yeah.
Yes, ma'am. So I'll be taking the first case. This case, going into the details, he is a 26-year-old male, private employee in Chennai, came with the chief complaints of yellowish discoloration of eyes and urine for past 10 days. History of presenting illness, yellowish discoloration of eyes and urine was insidious in onset, progressive in nature over a period of 10 days. This jaundice was preceded by the symptoms of anorexia, nausea and vomiting for 2 days. There was also one episode of fever which was low grade, not associated with chills, and subsided with taking antipyretics. He had generalized tiredness and fatigability. This jaundice episode was not associated with any pruritus or pale colored stools. There was no any history of abdominal pain, abdominal distension, no history of any bleeding manifestations like hematemesis, melena, or there was also no history of any altered sensory. Yeah, patient doesn't give any recent history of alcohol binge, or there was no any alternate system of medication. There was no history of blood transfusions, tattooing, or abdominal surgeries in the past. Patient does not have any comorbidities. Patient is a 26-year-old male. He gives history of being homosexual and intake of IV drugs for past 2 years.
So how did you get this history? On his own, the patient was disclosing, or he came out with this information, or there was a disclosure by the patient himself?
No, initially patient did not come with this details. After probing him, like asking leading questions, then only patient has given the history.
Yeah, so basically, again, I think this was the same boy where we said, where do you stay? And he was saying that I was working in one particular place, and he was staying in a hostel, men's hostel. And then we asked him how many roommates were there. Then he said 5. When he said that 5, then we just asked him very, in a very positive way that please not to get worked up about it. But is there any other or different type of behavior you have amongst your friends? And then he came out with everything. His disclosure was quite frank. And because in a very close room discussion, we kept his friends, the other friend would come with him, he was kept aside. Okay, continue.
So on examination, he was conscious oriented, vitals were stable, icterus was present, there was no pallor, lymphadenopathy or pedal edema, there was no flaps or KF ring noted, there was no other signs of liver cell failure. Systemic examination, respiratory, CVS, CNS were normal. For abdomen examination, there were no any visible abdominal veins. No, abdomen was soft, scaphoid in shape. Liver was palpable 3 centimeters below right costal margin along the mid-clavicular line. Margins were regular, smooth surface, firm in consistency. Upper border at right, fifth intercostal space, liver span of 14 centimeters. It was non-tender. Spleen was not palpable and there was no any free fluid in the abdomen.
Continue.
So this was my case details. Coming to the syndromic diagnosis in this patient, he did not have an jaundice for a period of, he's a 26-year-old male with no comorbidities, giving history of being homosexual and IV drug abuse for past 2 years, presented with progressive non-cholestatic jaundice for past 10 days, with no associated abdominal pain or fever. Preceding the symptoms, he had prodromal symptoms like anorexia, nausea, and vomiting. One episode of low-grade fever was present, which subsided with antipyretics. He did not give any history of decompensations like abdominal distension, bleeding manifestations, or altered sensory. So my differentials in this case, I would consider as jaundice was preceded with prodromal symptoms, I would consider acute viral hepatitis as one of the differential in this case.
Continue.
Among the acute viral hepatitis, I would consider hepatitis B, either acute or reactivation of hepatitis B. I would also consider hepatitis A or E in this patient. As patient was taking IV drugs, I would also consider drug-induced liver injury in this case. As being a young male patient, I will also consider Wilson disease and autoimmune hepatitis.
1 minute, just hold on. Dr. LVK, you can ask me questions.
Behavior, and also he was a homosexual. So will you bring the retroviral disease in your background?
You have to mention that one. Yeah.
Yes, sir. Yes, sir.
Now, if you think there is a retroviral disease in the background, you think you can have a retroviral disease and associated liver disorder due to retroviral?
Yes, sir. Yes, sir. We should consider.
So if you have a retroviral disease in the background, what are the causes of liver disease you will consider in that such a background? Did you have any cholestatic symptoms?
No, sir. No cholestatic symptoms.
Okay.
So just tell what are the HIV and liver
HIV and associated liver disease.
Jaundice.
He had already high risk behavior, isn't it?
Yes, sir.
So what will be the liver diseases associated with HIV?
Sir, HIV related opportunistic infection.
Like?
Harish, you can also join.
No, you think, so if you have HIV and jaundice, so what are your differential diagnoses?
HIV cholangiopathy.
We can divide
Is it
into HIV related or other related, like other common causes of
yeah, so it could be
liver
related
injury,
to HIV,
or
it could be related to opportunistic infections due to HIV, or it could be unrelated to HIV, isn't it?
Yes, sir.
In case of HIV related opportunistic infection, first will be
No, supposing it's HIV related, let's not take opportunistic. HIV itself can produce jaundice?
Yes, sir. It can cause hepatocellular jaundice, and also.
Like what? So what are the causes of hepatocellular jaundice in a HIV, in a retroviral patient due to HIV?
One is due to drugs which we use for
First,
HIV.
most important thing is you can have hepatotoxicity due to drugs. Okay. Number 2.
Like it could be associated viral infections in the form of.
No, we are not talking. We are talking. Can HIV, de novo HIV, can it produce jaundice? What are the causes? No, associated acute hepatitis B, E, A is all of these things. So supposing.
Yes, sir.
Somebody said HIV cholangiopathy. Then.
Yes, sir. It could be malignancies like lymphoma or Kaposi sarcoma is one possible.
So it could be an infiltrated disease in HIV due to a lymphoma. Okay. Then
Uh,
you can have nodular regenerative hyperplasias in HIV and you can get jaundice.
okay.
Okay, so you can have an obstructive jaundice, you can have an infiltrative disease in HIV, which could either be infection or
It could be
malignancy. So you
malignancy.
can get a lymphoma and then you can infiltration. You can get HIV cholangiopathy, you can get nodular regenerative hyperplasia. All those
Again,
things
yes.
can produce jaundice in patients with HIV. What are the opportunistic infections which can produce jaundice in retroviral patient?
First would be viral, sir. Hepatitis C, hepatitis B.
Opportunistic infections.
Opportunity, Mycobacterium avium complex.
Yeah, so you can get granulomatous disorders in HIV due to Mycobacterium due to tuberculosis. Number two,
Tuberculosis, Cryptococcus.
what are the other?
CMV can cause.
Good. CMV can cause jaundice. Then can you get fungal disorders? Can you get disseminated fungal disorders, which can in HIV, which can produce cholestatic jaundice? Yeah, you can get, no? You can get in a retroviral, you can get sometimes fungal. Okay. The non-infectious disease, you can get infiltrated lymphoma. So you can get CMV, you can get histoplasmosis, you can get some of these disseminated fungal infections which can produce jaundice. Okay, so you should have a broad thing. So HIV per se can get into jaundice because, as you said, it could be drug induced, it could be associated opportunistic infections like fungal or tuberculosis. You can have neoplastic conditions in HIV like a lymphoma which can produce jaundice. And you can get sometimes nodular regenerative hyperplasias in the liver which can be. Then you can get cholestatic jaundice like HIV cholangiopathy. HIV cholangiopathy can be associated with de novo cholangiopathy or
infection.
So I think the roundabout way is when you have such conditions, you must also consider HIV.
HIV. So what
reverse, like cholestatic, it was
What else
cholestatic
can
jaundice.
produce HIV cholangiopathy? What other organism can produce?
Cryptosporidium.
Correct, very good. So you can get cryptosporidium also in the bile duct. You can get CMV also can produce in cholangiopathy. Okay? Cryptosporidium cholangiopathy. So these are all things which you should know when you patient. Apart from it, in a HIV, you can get, as you said, acute viral hepatitis. You can get drug induced if you take CAM or if it's got due to retroviral diseases.
Drugs.
And of course, Wilson's and autoimmune hepatitis.
Can move on.
Yeah. Go ahead now.
Yes.
Varghese sir.
BT? BT?
I am here. I have been listening. I think
Yeah, anything?
that was,
Yeah.
I think the combination HIV and other problems have been well discussed by Professor Venkatrakrishnan. And I think almost everything has been highlighted. Every point has been highlighted. Jaundice in a patient with HIV. That was the question. I think everything has been highlighted. I think let him proceed.
So we proceeded with the investigations in the patient. His hemoglobin total count platelet were normal, INR was normal, ESR was 16, CRP was 0.4. Total bilirubin was 12.3 with the direct of 6.29. AST was 304, ALT was 352. Alkaline phosphatase, gamma GT were normal, albumin of 4.1 and globulin of 3.5. We proceeded with the viral markers in the patient, which showed HBsAg, anti-HBsAg IgM, and HBeAg being reactive. HBV DNA quantitative was more than 1 crore international unit per ml. anti-HCV was non-reactive in this patient. We also have done HIV, which was reactive in this patient.
So he's okay. HIV was thing. Did you look for a CD4 count and HIV viral load in this?
Yes, sir.
Go.
Imaging
So
showed.
anything, we'll go back to this. So here you had a straightforward HBsAg is reactive, and HB antigen was reactive, and HBV DNA was also high, and so your anti-HCV is non-reactive. Are you happy with it, Dominic, or you would like to do a?
I would like to do a HCV RNA qualitative at least.
Quality or quantitative? Because sometimes, why is it you want to do, in spite of HCV non-reactive?
Because in immunosuppressed, antibodies might be not expressed.
You may get a delayed birth to antibody, so it's always better that we check a HCV RNA.
Quantitative is better.
Quantitative, because sometimes you can get both hepatitis B and C co-infection in a retroviral. Okay,
So
we will discuss it. What happens when you have this one? So here you have.
So LVK, just in case this patient did not give that history of high sexual behavior.
Not sexual is okay, but
no,
here
are we justified in doing an HIV in this patient? Do we need permission from the patient? Somebody does not give the history, no? Here, somehow we disclosed it. But if a non-disclosure, are we justified in getting
no, but we need to explain to them that
okay.
as a part of the viral serology we do it, but we need to take a permission before you do retroviral in these patients. At least we have to take a written permission in our institute before you do.
Ma'am, I have a point. I think one of the modes of transmission of hepatitis B virus infection is also sexual route, an important transmission route. So we have to ask, it's not only heterosexual, it is basically unprotected sex. That's the main issue. Unprotected sex and multiple partners. These are the two risk factors. This is what we have to assess. Apart from his sexual orientation and people with the male-to-male sex or unprotected sex among them, or those with the multiple partners, these are the people who are at high risk. This aspect has to be, whenever we have an hepatitis B positive in an adult person, I think we have to ask this question, taking them into confidence.
Yeah, I think it's true.
And if there is a high risk behavior, we have to look for hepatitis HIV, definitely.
Yeah. Otherwise, we should, as you rightly said, I think that history taking is important. I do not know how easy it is or how difficult it is for the students to take that history in the exam. You know? As seniors, it is easier for us, but as postgraduates, I do not know how easy it is for them to get that history out.
No, I think these are the issues which are a little delicate. How I approach the problem is that I have to say, see, I have to ask you some personal questions which may be a little unpleasant for you. And I also make sure that no one else is in the room. Okay, that's another thing. They may even be unhappy about the attendant remaining in the room. We temporarily keep them out.
Including nursing staff. No, this man didn't disclose until the nurse was there.
They will always try to look back and see whether the door is completely closed, or there is anyone else. Even the junior doctor sitting alone, sometimes they will be still hesitant. But I will keep a doctor, but other staff will be away, and I will tell them that, see, I am going to ask you some questions which may be unpleasant for you, but for my diagnosis, these questions are important. I'm sorry if I hurt you, but these are very important questions.
Sure. Yeah.
Okay. Sorry. This is how we proceed. Please proceed.
So imaging in this patient, ultrasound abdomen showed enlarged liver of 15 centimeters with altered echo texture, no surface nodularity, no focal lesions, no calculi in the gallbladder, portal vein, hepatic vein were normal, IHBR and CBD were normal, no free fluid in the peritoneal cavity. Fibroscan was done, which showed F2 to F3 fibrosis, no steatosis. We went and did this CD4 count and HIV viral load. HIV viral load was 12,100 and CD4 count was 400 in this patient. So, how to proceed with further investigations and
How much was the CD4 count?
400.
400. Okay. Okay. What's the significance of that count?
Usually in now guidelines are telling irrespective of the CD4 count, we have to treat the patient.
Now, if your CD4 count is more than 250, then your opportunistic infections are low.
Yes.
Okay, it's very uncommon to get cryptosporidium or any other things when your opportunity is low. So above 400, probably your opportunistic infection causing this sort of jaundice is low. Here, of course, we have straight away hepatitis B. And
I
your
think the
alcohol has not
management,
shown any.
every HIV patient, we have to know the CD4 count, no? In this scenario, the exact value of CD4 may not be of relevance because
Yes.
irrespective of the CD4, we may treat. But I think in the routine management of HIV, CD4 count has to be there because that will give us some an idea as to what type of a patient we are dealing with, who are susceptible to lot of other infection or not. Over to Professor LVK. LVK, please.
Yeah, yes, sir.
Over to you.
So how to proceed with further
Are
investigation?
we taking up the discussion or taking up as a talk, short talk? You want to give it a short talk towards the end, then we just move on.
No, it's again, we'll go over the discussion and
We'll go with the discussion and then give a summary.
how to
Okay,
proceed
fine.
further.
Yeah,
I don't
yeah.
have anything to add.
Sure, sure.
So you can go with the discussion, Doctor.
Yes. Yes, sir. Sir, discussion for this case, it's not.
The only thing is I would have done a HCV RNA viral load. Okay.
Yes.
So we should know that when a patient, it's important that we also have a HCV RNA viral load in this. The second thing, somebody asked about F2, F3 fibrosis. I do agree. Fibroscan in the presence of an acute hepatitis will show some altered cap as well as high things. So I don't think we should probably reassess it after the whole thing settles down. So that is one thing. And then you please, go ahead. No, you go ahead and so patient was started on heart therapy, including TAF. Bilirubin enzyme settled over the next 3 weeks.
Sir, I have a doubt in this case because this case is acute hepatitis B in a 26-year-old male, which is showing anti-HBC IgM being reactive, HBeAg being reactive, and HBV DNA of more than 1 crore.
1 crore,
Usually, we will not start any antivirals for these patients.
No, but you look at it when you look at acute hepatitis B. Have an idea of what will be the HBV DNA viral load usually?
Usually, it will be more than 10 to the power of 7.
No, in acute hepatitis B. Generally, it will be less. So what we have a cutoff is if it's more than 10 to the power, less than 10 to the power of 6, then it could be an acute hepatitis B. According to Rajendra Reddy, it can go up, but when it is more than 1 crore or 10 to the power of 7, it's possibly mostly a reactivation. And sometimes when you see in acute hepatitis B, generally sometimes the viral load will, because the jaundice is caused by immune, this one. So when the viral load is more than 10 to the power of 6, we always think it's reactivation. Certain countries like, say, South Africa, there is nothing like acute hepatitis B. Everything is being taken off like a reactivation of things. So here, more than 1 crore, that means I would feel that is possibly reactivation. He has had a high risk behavior, so he could have had a chronic Hep B with a reactivation because of his retroviral thing. So with a more than 1 crore, I think we are justified enough to start antiviral and see how it goes through. Majority of the times, you may be able to give it for a year or so, and then you keep an eye on the HBV DNA viral load. You stop it only when he becomes HBsAg negative. HBsAg negative. So it looks as if that this is possibly a chronic Hep B with a reactivation. And because you are starting on tenofovir alpha-amide, things have settled down. That's what I think I would do. because it is more to the 10th. I keep 10 to the power of 6 as probably cut off for it.
According to Dr. Sareen, no, he says that all HBV acute hepatitis
Nowadays,
or
all are
reactivation. Yeah, he says
Or
all
reactivation. That's
reactivation.
also told me. In Africa, anybody who comes from Africa, it is all reactivation. So acute. So now more or less we are seeing that most of this will be a reactivation.
And the
Unless you have a
reactivation,
patient that received
what
a
would be the trigger?
blood transfusion, and then probably within 8 weeks they come back with thing, then it could be. But here in these situations where a patient has got a high risk behavior, then it is almost always that this will be a reactivation of chronic hepatitis B.
But
So
what would be the trigger? LBK, what would be the trigger for the reactivation HIV? Is it?
No, I think what can happen is when you're immunosuppressed, the HSB does not reactivate. So when you start giving medication HIV and there is a what we call as restitution syndrome, then this could have got reactivated. That is one thing which could have happened.
But you not started, no? The treatment for heart was much later. Much later. Yeah, that is the TAF was incorporated in the heart therapy.
Maybe retroviral immunosuppression and then it could have got reactivate. Generally, but when you give chemotherapy and all, they don't reactivate. Only when you start withdrawing chemotherapy, there is that immune this thing which gets reactivated.
And
yeah, normally HIV should actually suppress. HIV actually produces immunosuppression, and therefore it is like our carrier state, where there is not much of inflammation in the liver. But presence of HIV actually accelerates the progression of HBV also. So there is another problem also. So it could be possible that this patient had a background HBV infection, which got accelerated due to the HIV infection, and at some point of time, but here there is no zero conversion. There is no zero conversion to say that is okay. So it could be that HIV disease itself would have produced the trigger. That is what we don't have any other cause in this patient. No, heart has not been started. If anti-HIV treatment has been started, we can say it is a reconstitution of the immunity. So that has not happened.
yeah. The other thing is whether he does have an HCV RNA, no? That maybe HCV was a trigger. We don't have the HCV RNA. That I think we made a mistake.
Yeah, we have not done it. Yeah.
That we have not done. What would have been the transmission this patient, vertical or horizontal? That we can come to any conclusion? 26-year-old. LBK,
regarding the
how
hepatitis B.
B, yeah, B.
So by 26, normally E antigen should have cleared, no?
Cleared.
It was vertical.
Which is it, ma'am?
No, how do we know it's horizontal or vertical transmission in this particular
This
issue?
could have been a horizontal.
Yeah, so most likely horizontal.
Horizontal transmission.
So you can just
The
tell the
horizontal
PGs, no?
transmission takes place even in the families. It's not necessarily always vertical.
Yeah, you can
Even in
just tell,
families, sometimes somebody is infected, you can get a horizontal transmission of chronic HB.
can you just summarize how to differentiate horizontal versus vertical transmission in a patient at
Vertical
this age?
generally does not. Most of the times, vertical are asymptomatic, and then you are incidentally found out, and then they keep under non-replicated for a long time. Then they reactivate. Unless we check his family, we do not know whether there was any vertical transmission.
Okay, Bhargav, next question. What choosing drugs for heart therapy in co-infection? Any comments on that? Choice of therapy.
Because most of the drugs used for HIV also cross-react with hepatitis B, no? So that is one issue where you have to have a close discussion with the HIV specialist when they start the treatment. And another thing, the toxicity is another thing. So drugs can produce a severe liver injury that will produce worsening of the liver function. So that is another aspect. And this post reaction and drug toxicity, these are the two factors which we have to consider, and we have to discuss with HIV specialists before starting drugs like TAF or other drugs. Any HPV drug, I think we should discuss with the HIV specialist, because we may seriously compromise the treatment of HIV. by adding one drug from our side. Because HIV therapy is a multi-drug therapy, not a uni-drug therapy. Because otherwise there will be a lot of problems subsequently. Like in process, we give multiple drugs for HIV. For HPV, we generally give only one drug. So this one drug given for HPV should not seriously hamper the management of HIV infection. So there has to be close discussion between both specialists.
The treatment of HPV will like a monotherapy for HPV, even though you have a co-infection. I think it is more thing, and most of these HIV things continue has tenofovir. There are only few drugs which we thought we'll review later where you cannot give tenofovir according to that. So otherwise, some of these people they include tenofovir as a part of the treatment for HIV. So I think that's why they respond well to these things. And the guideline says that you give hepatitis B monotherapy, just like a hepatitis B monotherapy, and you have almost same amount of response. Same amount of response when you give HIV, like a HBV monotherapy, HBV to HIV.
Okay.
Choosing drugs for heart therapy in co-infection. In hepatitis B, do we have any specific thing about choosing infections?
Lamivudine or tenofovir based regimens.
Do you have any literature on that? There are a lot of literature of choosing drugs in patients with hepatitis C, but in hepatitis B, I think we are left only with tenofovir alphanamide or tenofovir.
Professor Venkat, if the heart therapy already contains a drug like tenofovir, then we don't have to add anything. We just have
Anything
to
else?
continue.
Yeah, we don't need to add.
Just continue.
Yes, correct.
That's a close discussion between both specialists will have to be there.
Sure. Let's go
So
back.
here the take home is, I think we can start off heart therapy. I'm not very sure with this. I think this viral load, I think they'll definitely start. So they would have started some medication with tenofovir, and because this was an acute reactivation, what happened in the follow-up? Did all the bilirubin, everything came down, and what happened?
It's settled. Yeah, the whole thing
Now it
settled.
has come down, is settling down, but I think how long will go? Anyway, this tenofovir will be continued, and most of that will continue. Tenofovir, depoxylate. I'm not very sure if TAF is included there. Most of the combinations will have this tenofovir depoxylate. So I think this patient should. Only thing is we will follow up these patients with the serial HBV DNA viral load. And even if the viral load is low, and I think they will continue this tenofovir because a part of the treatment for retroviral. The only time we take a seroconverted is after 6 months or 1 year if you become HBsAg positive, HBsAg negative, which may be unlikely that he may have continued chronic hepatitis. He may be a chronic hepatitis B, and we need to continue tenofovir and keep rechecking HBV DNA once in 6 months or once in a year.
In case he converts, and it becomes negative as an acute hepatitis B, then
Converts, what will happen is, madam, all this retroviral combination also will contain tenofovir, so they continue tenofovir.
Yeah. So anyway, he continues. So he just continues.
We have to continue, but only thing is to say that we'll after 6 months check your HBsAg and anti-HBs.
For the HBV conversion.
Yeah, but anti-HBs maybe producing anti-HBs. So anyway, we will continue tenofovir. This patient maybe it is very good that I think this was an acute Hep B or acute reactivation of Hep B, and he really responded to TAF. And they will start him on retroviral, which will contain tenofovir as a
combination,
as a part of the drug. He should do well on this.
Sure. Any questions in the chat box on this issue? Is it acute hepatitis reactivation? Is there any chance of iris in this patient reconstitution? He's not been started, no? He's been started on the combination therapy, so we cannot, right now he's settled, so less chance that it is an iris. Then horizontal transmission.
Have they started on retroviral now?
No, he's just continuing on the same regimen. The tenofovir.
No, but they will not give only one medicine for retroviral, so they should have given
the combination, yeah. So we're not sure about the combination. They went to general medicine department and they continue. So we discussed about the horizontal regimen. Most regimens contain tenofovir. Yeah. So we answered most of it. Can we just move on to the next case?
Before we close, I just want to say that in any hepatitis B person, especially if the person is young, usually we look only at the parents, especially the mother. We have to look at all family members. In a study conducted by one of my residents, found out that the same prevalence we found in another sibling, and the same prevalence we found in the father also. Okay, so it's not mother alone. We have so horizontal transmission
Yeah.
occurs in family, and in fact, one has to screen all the people who are living together under the same roof, whether
Sure.
related or unrelated. All the
Yeah.
people living under the same roof will have to be checked.
Sure. Agree. Move on.
I'll be presenting the second case, ma'am.
Okay, so summarizing the B, hepatitis B with co-infection. LPK, we'll be discussing the treatment regimen towards the end, or we conclude that?
No, hepatitis B with co-infection.
That's it.
I want
We
to
just
tell you
continue.
something.
We just
What
continue the
happens
treatment.
is the various presentations. This patient has come to you before treatment, and he has presented like an acute reactivation for chronic Hep B. But occasionally, what happens is we have a very high index of suspicion when you have Hep B. So these patients will be referred to us when there is an persistent elevated liver enzymes. So when they have a persistent, majority of the times we see in our OPD is from the infectious diseases patients coming to you with elevated liver enzymes, or when they have. So at that point of time, when we look for that, HB is HBV negative, but one of the things is when you do a HBV DNA viral load, it may be elevated on this. Some of the patients may not be on a tenofovir drug. So at that time, they may come to you as a chronic Hep B. And those are times when we have to treat them, these patients, like a chronic Hep B. Second time, they may come as a reactivation of a chronic Hep B with chronic Hep B with jaundice, and then it's easy for you to pick it up. When you have chronic Hep B and chronic Hep C, generally, even without a thing, even without a retroviral disease, if you have HPV and HCV, generally HPV will suppress hepatitis C, and then you need to treat hepatitis B and keep following up the hepatitis C. That is what usually when you get Hep B and Hep C. That was a time when there was interferon only for Hep C, and then we had these problems. But generally, it has to be Hep B, Hep C. And at the same time, when you are treating hepatitis C, even when you're treating hepatitis C, you're always supposed to look for an occult hepatitis B infection. Why? Because as you treat hepatitis B, it can unfurl occult hepatitis B infection. So that is what they say. One of the things of treating hepatitis C is that it can suddenly unfurl hepatitis B. So you need to know whether the patient has got an occult hepatitis B infection, and if he's got an occult hepatitis B infection, you need to keep looking for HBV DNA during the treatment of hepatitis C. So sometimes you can reactivate hepatitis B when you're treating hepatitis C. That is what we should do. So done. So these are things which you think, but most of the time, since they use tenofovir, these patients do respond well, and we are able to keep the hepatitis B in check in these patients. Okay.
Okay, just to digress from this, so there was one referral from general medicine department. A patient HIV positive was on this drug called atazanavir, okay, combination. And the referral was for a bilirubin of 21 milligram per deciliter with a direct of 1.2. So to me, it was only Crigler-Najjar type 2 which I knew, where you can have a bilirubin of 21 and an indirect of this thing. At that time, I didn't realize that the patient was HIV positive. But the general medicine people, they went through the literature, and he was on this atazanavir, and that it seems acts on the UGT1A1. So if a person is so it acts irinotecan and atazanavir both act on this UGT1A1. So in a patient with HIV, if you have an indirect hyperbilirubinemia of 21 or 22, 23, behaving like a Crigler-Najjar type 2, where you give, barbital, So it behaved like that. And then we saw that in the literature, there are reports saying that atazanavir acts on this UGT1A1 in patients who are deficient. They can have this hyperbilirubinemia. So this is just certain things that you should know. Heart therapy, indirect hyperbilirubinemia. Actually, I wrote there, Spitmanajah typed and I walked off and I said, get phenobarbital. But the department looked into the heart therapy and they realized, and I think all should, three drugs, irinotecan, atazanavir, both act on the UGT1A1. So it acts in that pathway for conversion. This is for the postgraduates, okay? Okay, move on to the second case.
This is a 52-year-old man presented with features of easy fatigability, mild anorexia, right upper quadrant pain. Patient is a known case of HIV on heart therapy for the past 15 years. He had one episode of jaundice 12 years back, no history of GI bleed, no decompensation in the form of ascites or encephalopathy. He consulted his physician and evaluation showed elevated transaminases. So ultrasound abdomen was showing fatty liver with increased echo texture and prominent caudate lobe. No previous history of any blood transfusion. No, he had multiple injections with the local physician in his place for episodes of fever and cough. He was referred for further evaluation of elevated transaminases. Drug history, he was on tenofovir and dolutegravir. His recent CD4 count and viral load were not available. History of CAM intake for 1 month for his fatigability, which was in the form of Siddha medicine. Various issues of this patient were being retroviral positive on heart therapy for the past 15 years. He has elevated transaminases with symptoms of fatigability and weight loss. Ultrasound showing fatty liver and increased echo texture. There is a caudate lobe hypertrophy with volume redistribution, which is feature of cirrhosis. And also there is a additional history of CAM intake.
So this what happens actually. This is where how the patients come to you from your medicine or the thing where a patient is on retroviral on treatment 15 years of heart and then has symptoms of fatigability and weight loss. And you will have an elevated liver enzymes. There's no elevated, there's no bilirubin and nothing. He has no decompensation and everything. And he's got some CAM intake. Okay. Next. So what will be the, so is the retroviral?
You won't consider SOS in this patient. Someone has asked me, it's not like SOS, no? This is just a transaminases.
SOS comes more dramatically. It does not
come like this.
Thing that does not come this way. But you can you can get one NCBH like picture in a chronic HIV. You can get a splenomegaly in chronic HIV. It's one of the reasons for your non-cirrhotic portal hyperfibrosis is one is now HIV. So you can so when you have something like an altered LFT in a patient with a retroviral patient, I just want you to tell me what will run into your mind. What are the causes? There's no jaundice, only elevated LFT. There's no decompensation. Nothing.
Sir, as like we already discussed, in the form of like drug-induced, because the patient is on long-term, like 15 years of
so
heart
this
therapy.
Patient, he was on dolutegravir and tenofovir. So then one other thing could be there.
The other thing is like a patient is also having features of anorexia and weight loss. Like other possibility is a viral prodrome, like secondary viral infection or a reactivation in a patient of HIV.
You can have Hep B, Hep C.
Chronic hepatitis, no? Chronic hepatitis.
You can have chronic hepatitis. You can have drug-induced hepatitis. You can have chronic hepatitis then.
And this patient also had a history of CAM intake. So that is one more.
That's what we said it will be drug-induced.
Drug-induced. The other thing is like opportunistic infections, other opportunities like fungal, crypto.
Lymphoma.
Could again be some sort of a gram-gram-itis infection.
And also a lymphoma.
Or lymphoma, or it could be opportunistic infections. So these are things which you really think. So it could be Delhi, it could be some granulomatous infection, it could be chronic viral hepatitis. All these are the possibilities in a patient. Okay.
His
And it
hemoglobin,
may be totally unrelated, no? NAFLD,
Yes,
any of all the other possibilities that we keep in mind. Autoimmune, drug-induced autoimmune hepatitis,
alcohol,
hepatitis,
and
alcohol histories.
If he's taking alcohol, definitely alcohol.
Related and unrelated. I think that's the best way to go to. Okay, continue.
hemoglobin is 10.3. Total count is 7,100 with neutrophil predominance in the form of 71%. Lymphocyte is 29%. Platelet count is
1 lakh. Yeah.
1,28,000. ESR is 32. CRP is 1.6. Blood sugar is 116 and creatinine of 1.4.
Creatinine of 1.4.
LFT shows total bilirubin of 1.2 and direct of 1.2. 1.8 total bilirubin with the direct of 1.2. AST is 342. ALT is 218. Alkaline phosphatase is 116. Total protein 7.6 and albumin is 4.3. INR 1.12. Normal. Hepatitis B, HBsAg is negative. Anti-HCV is negative. Core antibody is negative. Serum ceruloplasmin is 22 and ANA profile is negative.
So what next?
As already discussed, there is a chance of being HCV, anti-HCV being negative, falsely negative in these patients. We can do HCV RNA in this patient.
Now you should do both HBV DNA and HCV RNA viral load. Okay.
So LVK, you can just tell us, both you and me, when all should we do a DNA and an RNA in a patient?
I think when patients are immunosuppressed, sometimes diabetic patients on hemodialysis, especially renal failure, very elderly immunosuppressed patients on chemotherapy, patients are under dialysis. That's a very, very thing. You pick up sometimes acute HCV on a dialysis where your HCV RNA negative, HCV will be negative, but RNA may be positive. So these are cases where you do go ahead and do an RNA.
But in the presence of transaminitis, no?
Yeah, in the presence of a transaminitis. Not in a transaminitis. Whenever there is an unexplained transaminitis, I think if all your things are negative, in such a setting like that, you try to do an HCV RNA. So we did both and found that he has had a HCV RNA of 1 crore 17 lakhs, nearly 17 lakhs international units.
Ultrasound abdomen shows fatty liver with increased echotexture of the liver. Portal vein is mildly dilated. Upper GI endoscopy showed prominent esophageal vein.
So his diagnosis is patient with retroviral has come with unexplained transaminitis, has come with HIV and HCV co-infection. So can we have something on that?
LVK, patient is already on heart therapy, no?
Yeah, he was already heart therapy. He was sent to us because of persistent transaminitis.
So where did he get this HCV from?
Ma'am?
How did he acquire the HCV?
No, he comes from a place called Annur here, close to where is the big thing of HCV. Hotspot. Now we have most of them we have cleared that virus for the last 10 years. Thanks to this Tamil Nadu thing. Because this Annur had lot of let me not shout, it is all the RMP practitioners and he took multiple injections. Multiple injections. So the thing. So
there was a history of IV drug abuse.
There was no IV drug abuse. It is the parental injections which they used to go and take with the doctors. Most of these doctors were RMPs, registered medical. You remember that?
RMPs. Yeah.
So in fact, we had a lot of hepatitis C from that area.
Something like schistosomiasis with HCV.
Yeah, we had hepatitis C. So much so, we had to go and we couldn't directly go and access those doctors because they were getting very hurt about this.
So I think an important message what I got from this case is that while the patient is on treatment and has a transaminitis, I think we should go back to the DNA and do
so we had this HCV RNA. we had initially it was also, and then we changed the practice. The community medicine went and changed the practice of the whole thing. And we have been treating this patient. And thankfully, after DAA, we are able to treat most of these patients. We changed the practice because the word went out. There's a lot of HCV and HIV, and people were not getting brides and bridegrooms from this place. So the whole thing came, and we were able to change the whole practice. And we had to do very, very carefully.
HIV was also high in this population.
Yeah, it was in that population very high.
Salem has that pocket, no? They have the truckers.
The pocket.
The truck drivers. No? Salem has a pocket.
Kannur Satyamangalam area had a lot of HCV.
Sure, that's good.
And that's what happened in this group.
Okay.
In fact, one of our first papers with DAA of 145 patients, which we presented in Tamil Nadu ISG in 2015 or 16, was most of the group was from this place, actually.
Okay. You can take up the discussion, Harish.
So this is what happened in this patient.
HIV decreases the likelihood of spontaneous.
So how was the patient treated?
No, we started him on antivirals. So we started him on now sofosbuvir and velpatasvir. Now we are continuing the treatment now. And
you continue for 6 months.
He has responded to treatment now.
6 months.
Yeah, it's now 6 months.
6 months.
6 months. And then so I thought I'll just put up on this literature of what is new in hepatitis C and HIV.
Sure.
Shall I go ahead, sir?
So this is the impact of hepatitis, HIV on hepatitis C, because spontaneous HCV clearance is only less than approximately 5 to 15%. You go ahead, Dr. Harish.
HIV decreases the likelihood of spontaneous HCV clearance to approximately 5 to 15%. So it accelerates the rate of liver fibrosis and a more aggressive course of liver disease. Also, development of hepatocellular carcinoma at an younger age and have a more aggressive tumors. Screening anti-HCV has to be done. HCV RNA has to be followed by a anti-HCV level, antibody level. If strong suspicion, despite antibody negative, like HCV RNA.
Even if you have a strong suspicion, kindly do a HCV RNA viral load.
False negative rates are up to 3.2% in persons with HIV, with most of the false negative results occurring in persons who have CD4 count less than 200. Next slide. These are the various treatment regimens. Treatment-naive patients with genotype 1A and 1B without cirrhosis. The regimen consists of sofosbuvir with ledipasvir for 8 weeks for persons with HCV monoinfection and baseline HCV RNA less than 6 million international units per ml. But the duration should be 12 weeks for the persons with HCV and HIV co-infection, regardless of their baseline HCV RNA level.
12 weeks, okay.
In case of treatment-naive patients with genotypes 1 to 4 and patients having compensated cirrhosis, the regimen is glycaprevir with pibrentasvir for 8 weeks for those patients with HCV monoinfection, and it is for 12 weeks for the patients with co-infection of HCV and HIV.
So now if you look into this treatment guidance for hepatitis C with or without HIV, now we have only velpatasvir and sofosbuvir, okay? But now the guidance by EASL in 2021, if you look into it, it is velpatasvir, sofosbuvir, number 1 combination. The second combination is velpatasvir, sofosbuvir and oxaliprevir. If you have a 5 mutation of in a protease inhibitor mutation. The next combination is this glycaprevir and pibrentasvir. Then you have elbasavir and grabazobavir. These are the drugs which are now indicated to treat hepatitis C. I think they have largely given up Sofosbuvir comes only in the combination of velpatasvir or ledipasvir. They have given up other drugs. So these are the treatment either with HIV or non-HIV patients. Okay, so these are the drugs which are now indicated to treat hepatitis C in 2021, from 2021.
For us, it is
So,
only Sophos plus Valpacha, no?
yeah, if you have a cirrhosis, it goes for 12
12
weeks. If
weeks.
you're not having cirrhosis, it goes for 8 weeks.
8 weeks.
Can we have the next slide? Just see the next slide.
But won't you consider the HCV positivity and continue for 6 months if it's erotic? You will continue for six months, no? You will continue for 6 months, no?
If we are doing sofosbuvir, velpatasvir, now it is indicated for in a cirrhotic patients for 6
6
months
months, yeah.
without ribavirin. If you're going to use ribavirin, you give
Then
it for
12
3
weeks.
months.
3 months, 12 weeks.
Antiretroviral medications, NRTIs, abacavir, emtricitabine, and lamivudine and tenofovir alfanamide can be used safely with all the recommended HCV regimens. Caution should be used with sofosbuvir, which increases the drug levels of tenofovir.
So when you give sofosbuvir and tenofovir, the increase of tenofovir, which can lead on to some renal toxicity. That is what is important in this.
Next slide. NNRTIs, doravirine and relpivirine can be used safely with all the recommended HCV regimens. Efavirenz and etravirenz should not be used with any of the recommended HCV regimens except for sofosbuvir and ledipasvir combination.
So never use everything and etranacogene because they are highly hepatotoxic, and then don't use this particular drug. That is very important for you. So it's in hepatitis C, it's important you look at the drug interactions, because when you use sofosbuvir and tenofovir level can go up. If you use etravirenz and etravirenz, then you cannot use with any of the treatment HCV recommendation except for ledipasvir and sofosbuvir. You can't use elbavir or resvavir or glycatabir or perimetrisvir. So these are things which you can, or you can't use it with voxelprevir. So this is what you should know in hepatitis C treatment, which antiretroviral you can use and which along with recommended HCV regimens.
By ignorance, all these drugs are available, no? On the heart therapy.
Yeah, quite a few of these drugs are available now.
Okay. I think what your postgraduate students should know is
So it is
drugs heart which is available and what is
and
practical.
then use it according to that.
Accordingly to that.
So,
This is okay. These drugs are on. Can we go to the next slide? I have one more slide.
all
All
ritonavir
these
and
drugs, we should know which one to use with the HCV recommended regimen. There's no problem with hepatitis B, but with hepatitis C, there is definitely we need to know which drugs of heart, which drugs of recommended hepatitis C have to be used along with those drugs.
next slide.
So can you? So these are the studies which have shown that if you have HCV, HIV co-infection or HCV more infection, the SVR rates are almost equal. Even though you have HCV, either use elbasvir, gasabavir, glycapepimacin, ledipasvir or sofosbuvir or sofosbuvir valproastrel, you will find that most of the drugs when you have HCV and HIV infection are as good as treating like a HCV mono infection. So it is important that you treat HCV and HIV as HCV mono infection, but make sure that the combination of drugs can be used. So that you do not have any of this side effects, because when you use retroviral versus recommended HCV treatment. That's what we should know.
I think we can remember the latter two, no? Ledipasvir and Sofos with Sofos and Valpacha. So at least to that extent we can answer with this, we can quote this particular paper for genotype 1. Is there any difference for other genotypes? I think this theory bit they can read, no?
Yeah. This I think you can read up. So
yeah.
Okay.
Unless you have the basics.
The only thing we want to tell, you can just skip this, please. Much of the drugs are not there, you can skip. So what I just want to say with this is, If you have you have a HCV, HIV, you have a big suspicion. When there's elevated transaminases, apart from ruling out the thing, look for HCV RNA viral load. And if the HCV RNA viral load always should be elevated, despite HCV being anti-HCV being negative. And when you do on the drugs, now the drugs are sofosbuvir, velpatasvir, sofosbuvir, ledipasvir, and then it is glycemic pyrindosvir and elbazavir and grasbovir. So you need to have the correct drugs to use it along with the retroviral drugs so that it does not produce any toxicity. That is a problem with it. And majority, and the important thing is the response rate of HCV and HIV co-infection is almost like HCV monotherapy with these drugs. And if it's cirrhotic, we continue it for 6 months. Otherwise, most of the newer drugs, you can do it by about 12 weeks. They have not shown any place of ribavirin in HIV, HCV co-infection because it produces a lot of hemolysis along with other drugs. So we don't use ribavirin. So I think you should know all these and always look at most important in HCV, HIV is drug interactions, which heart therapy you use and which HCV recommended therapy you use in these patients. That's what I think we should know. And you should remember that the progression is faster, clearance of HCV becomes lower, and you can get HCC at a much lower age than in these patients.
But do they go through a process of cirrhosis, or it is fibrosis and it goes through that pathway?
From fibrosis,
Fibrosis and cirrhosis.
HCCs, and they occur in a much younger age.
Because normally you would expect it much later, no? HCV, cirrhosis, HCC.
I would recommend that all of you should read the HCV guidance treatment of 2021, EASL's guidance. They have now come out what are the drugs available and what will be the future drugs which you are going to do with HCV. I think they have given up on daclitazavir and all those things.
Okay. VT, your comments.
Yeah, I think the topic has been well covered. I think we have to, students will have to read up a lot of theoretical aspects of drug interactions between these drugs.
But I think in the exam they may not ask too many questions on this, but I think that those points, no, which basically that 6 months treatment, outcome is same as mono infection. I think those important points and the need to do an HCV RNA. Because I think the rest of it,
most important is an abnormal LFT in a person who is on heart. That is important.
It's important.
Look for HBV, HCV ordinary markers. If negative, look for DNA and RNA. That's the most important lesson for the day.
Sure. Sure. Any other questions?
And regarding that sexual behavior, I want to share an incident where one of my PG was publicly stating in the ward rounds that the person is homosexual. I think after the ward rounds, the patient disappeared. So you have to look at the sensibilities of the patient also when you tell those things in the sexual behavior in a public place. You can say he has a high risk behavior and tell your boss in confidence what exactly they meant, rather than telling publicly in front of other people about the sexual behavior of the person. Which I think we should take extra care about that. And regarding youngsters with hepatitis C, I always finally ask a point blank question, because in youngsters, IV drug abuse is the most important reason. So I will take them into confidence and ask them straight, have you ever taken IV drugs during your college days or any time? Tell me, I am not going to find fault with you. We have treatment, but just want to know. And most of them will come out. So we have to take them into confidence. That's very important. Before winding up, I think I have to ask a question to the residents, point to ponder. In an IV drug abuse, the prevalence of hepatitis C is extremely high. In Northeast Angle, it is almost 90%. But the prevalence of hepatitis B is around 12 to 15 or 20%. Why this drastic difference between the prevalence of two highly infectious diseases and both can come through the IV route? There is an actual explanation. So you have to read and find out that explanation.
It's much higher in IV drug.
IV drug, hepatitis C, no?
Next is hemodialysis and then blood transfusion.
Yes. But hepatitis B is not that high.
By the same mode of transmission.
Yeah, same mode of transmission.
You can tell us the answer in the coming Tuesday.
And also people should know what is the rough prevalence of hepatitis C in different parts of the country, the northwest now. the Punjab and
hotspot. Meerut is a
Punjab.
hotspot, and all this Pakistan border, no, where they have drug trafficking.
Northeast and Punjab. Northeast and Punjab are high.
Pakistan India border, where
I
they
think
have a lot of
Northeast
drug
has been
trafficking.
overtaken by Northwest now.
Northwest, yeah.
Yeah,
Northwest.
Punjab.
Punjab, it's
Punjab.
because of the Pakistan border.
Meerut especially. Tyagi, no, he has got a huge, and down south,
Punjab is because of drug abuse
drug
plus
abuse.
and Pakistan border. Pakistan has got a high incidence of hepatitis.
See, drug trafficking. And in down south, we have, at least in Tamil Nadu, we know there are all these truck drivers, no? Because they go for long distance travels, so they are the ones that are at high risk behavior. Yeah. So I
There's
think
a study done by us in 2006 and published in Tropical Gastroenterology, Indian Journal of Gastroenterology, I think, prevalence of hepatitis B and C among normal population and high-risk population in a tertiary care center, around a tertiary care center in North Kerala. We studied all high-risk population like female sex workers, M2M, IV drug abusers, and because there is NGO for each of them. So we could go to them and collect blood of these people, and also from the blood bank we got data, and from the medical Gulf medical examination they also do all these tests mandatorily. So we got a data of 1,45,000 people and got the data and found out that in people with high risk behavior the prevalence becomes 4 to 4.5 times that of a normal population. Whatever high risk is there, no, slightly different proportion is there. So high risk actually, in high risk behavior, the chances of HPV, HCV infection is very, very high. That's it.
what was the prevalence? B and C?
In Calicut, the basic prevalence of hepatitis B and hepatitis C is 0.5 only, so 1 in 200. But in people with high risk behavior, it was 4 to 5 times. 4 to 5 times. Okay. Up to 3.5 to 5.5 the range. But in drug abusers, our prevalence was 82% for hepatitis C. IV drug abusers, HCV prevalence was 82.
So IV drug abuse seems to be more, no? As you rightly said, between B and C there's some difference there.
Even hemodialysis is about 18%. IV drug was very high, but overall prevalence is around 2 to 2.3%. It's just about 1.9 to 2.3%.
Okay, I think we can conclude the session. Thank you, NPK, thank you,
Thank you,
Viti,
madam.
for that nice session. And thank you, Harish and Bhargav, for taking us through this session. I think sometimes you should have such sessions, where we have just a discussion on topics which are not covered. So that's why we took up this topic. Thank you all.
Thank you, ma'am.
Good night.
Good night, ma'am. Good night,
Tuesday
sir.
we have a session, Viti, Tuesday.
Next Tuesday is actually research methodology,
Research methodology.
By Professor Narendranathan.
Okay.
And after that only, then also Vinay Kumar may take a class continues, or else we'll have another topic.
Okay, fine. Thank you and good night.
Thank you, ma'am.
Good night.
Thank you.
Good night. Good night.